Good morning. How are you? Better. Yeah. So good morning, everybody. Today, our Wednesday class. This is a device class, and it is regarding the CSP, conduction system pacing. And this time, Abbott has taken the opportunity to give the insight regarding their hardware and how the pacemaker parameters are being set. What are the advantages of CSP, number one, and how CSP of Abbott differs from the other company that Devi Priya will be walking through regarding this topic. So I will invite Devi Priya to come and give her presentation regarding the CSP and how the Abbott hardwares are different from the others. And regarding their specifications, we will be. Sorry, 1 minute. Over to Devi Priya. सामने कैसे दिखाते हैं? Good morning.
Thank you for giving this opportunity to present the system basic overview.
Just after only.
So the objective of CSP today we are going to learn is like basic understanding of what system basic happens. So comparing with the RD basic to the responder basic and like basic ECG where like how do we interpret the ECG when we are basic responder and understand the terminology whatever we will be looking after when we are basic responder through like the LVAD and the QR response for the GT and like what are the procedures for the implant steps includes the hardware of Abbott and how we can maneuver the hardware according to the patient's anatomy and like best practice is like how can we program the device depending upon the parameters we got on table with the AV optimization and the unipolar pacing, bipolar pacing, everything. That objective like this will be an overview which will be getting known like at the end of this presentation we will all get a basic idea about what we are going to do with responder pacing. So this like what is the conduction system pacing basically? Conduction system pacing is like it is a physiological pacing where we are going to place in the responder area like where from below the AV node there is a two separation called right manual branch and responder branch block. In normal conventional pacing we are going to place in the right ventricle either in the apex or septum which will be a non-physiological pacing. It will be like central conductions where the URL will be very broad and it might lead to heart failure for the patient if it is like consistently pacing for more than 10 to 15 years. So this conduction system pacing is like as per the physiological pacing, the patient's heart failure thing will be not there predominantly most of the time through many studies. We have called a most study. In most study, they have found that the patient who is having apical pacing more than 40% of the time, they might lead to heart failure in future. So this connection system pacing will be a solution for the patient to prevent to enter into a heart failure. So like in past we had like two kind of pacing, responder pacing and responder pacing. Responder pacing is like it's a very short targeted area and we might end up in screwing in septal wall of the RV or LV septal wall. So the disadvantage of responder pacing is like we can only GP setup we can map the responder and we can get the amplitude and we can pace it. In pacing also we might end up with high threshold or broad PRS. Sometimes it might lead to perforation in septal pacing and all. So like in past few years they have like abruptly changed from responder pacing to responder pacing. The responder pacing area is like below the responder mapping only. It's like like 2 millimeter or 1.5 millimeter below this bundle. Like when we are using an EP setup, we can place the bundle catheter in the hospital area and we can get the potential of hospital. Below that, like 2 millimeter or 1.5 millimeter horizontally, we can find left bundle area where the target area of the left bundle will be quite wide and we can place in the left bundle area or in the septal. We call it as a two kind of placing. One is like selective placing and non-selective placing. Selective placing is like we have only we are capturing the left bundle area. We call it as a selective placing, which provides like narrow PRS, or like rather than providing a septal capture, we get the narrow PRS in left bundle placing. We have non-selective placing, which includes the left bundle area and the septal area includes as well. So it will be like a kind of a fusion of left bundle and septal placing, which is also kind of like better than the RB placing. But the QRS morphology will be little wider compared to the selective, pure selective placing. So in selective placing, what I mean, through ECG we can go through how the interpretation, the discordance, like in which lead we have to focus. So in ECG, like it is like a normal 12 ECG setup in a non-EP setup. If it is in an EP setup, we can place our bundle lead in this bundle, catheter in this bundle, and we can focus mainly on V1, which is covering the conduction system of the septal region of the heart. So it's like normal. We have limb leads and pericardial leads from V1 to V6. We should like very focusedly place the V1 in a right area where the conduction system lies, like in the RV. In the fourth intercostal place, we have to place the right artery system. So this is the QRS labeling which we will be getting while we are placing. Like as we all know, Q is the first negative reflection and R is a positive reflection. So in V1, in the chest lead of V1 will be the most focused area because it is on the V node or near the bundle area where we place a lead. So we can find tall R there at negative Q and with a small R prime. So these are the key terms. Like that is the ECG which we follow. This is in the 12 ECG setup. In the precordial leads, we can get a short note of LVAT. LVAT is the term which is like in left ventricle activation time. It's like when we are placing the left ventricle, which is like when we are screwing the lead in the septal area, it will initially start with the left bundle area, like the branches which covers the left ventricle, activates initially. Like we want to find how fast it activates. So we calculate the left LVAT, which is like from the basic spike to peak of the QRS. So the range of LVAT should be around 50 to 80. 60 to 80 would be a nominal one. So if it activates fast, then the RP activates will also be very fast. So the QRS will be narrow. If our LVAT is 80 peaks, then the remaining, like nominally our QRS should be around 120. So if how shortening of the LVAT we are getting, that shortening of QRS.
So what is the nominal? Normally, how much?
60 to 80 will be the nominal LVAT.
It depends upon the LVB versus RVB?
Yes, sir.
For LVB, how much?
For LV setup, we can get around 60 to 70, sir. Remaining part will be the RV activation. So, for example, if we have 120 or 1 QRS, the shorter one will be the LV. So we can split the QRS into two parts. The first activation will be the LV. So we can measure from the basic spike to the peak of the QRS. If it is around 60, then the remaining part will be RV. So if the synchronized actually. We are not taking CSP into CRT. CRT is the best one. CSP is the backup of CRT. But though, like through the lead of which placing the setup, we can get the both. As we are placing the septal area, we can get the activation of both LV and RV, which leads to narrow QRS. So nominally for LV it's around 60. For RV, remaining 60 would be fine to get 120 QRS.
Yeah. So my question was, if a patient is having RBB pattern for which we are going for the this left area bundle branch placing, and second is LBB for which we are going. So LVAT is same for both, or it should be different?
Because RBB is the block of right bundle branch block where the LV is very active. So for that we focus on the RBB. For LBB patient we can focus on the LVAT because in LBB
so RVAT how much it you are?
RVAT should be around 70 to 80 because
Orbit, how you are going to see?
Orbit, we are going to see from the same peak of the QRS to, like, from the peak of QRS to the end of the QRS we are going to measure. Because the end of the QRS will be our RV capture.
Okay. Okay, if you are having in the slide, you just show me that also. If in the slide it will coming, just show me.
Yes.
Yeah.
So these are the three kind of capture. There is sector capture, selective capture, and non-selective capture. You can see with the diagram, like here is the empty sector capture happening. This is suspended. This is a suspended area. And this is a suspended area. We are going to capture in between the septal area, septal wall region, between the RV and MT. This will be like lab system approach only, but it will be not a pure referral capture. It will be a septal capture, but far better than the RV apical capture. So this selective capture is like in the referral area, branch area, where we are going to select, like, selectively place only the referral cells. In non-selective setup, it's like we are going to cover the both. It is a fusion of first one receptor and the selective capture. So it would be little wider than the selective capture. So nominally, if you are getting any both would be fine for rather than comparing to our normal conventional placing. So now we are coming to the lab setup with the like whatever product that we use, the hardware part and the lab setup. So lab setup basically includes our valid ECG, and if you are using the EP setup, we can use our Java calculators for the EP cable to fix it over the EP, and PSA which we are in the programmer, and we can use our adapter also, which is a crocodile adapter. The product will give like 3 products would be sufficient enough to do left bundle capture, which is like normally Abbott has the lead which we are already using for conventional lead. We can use it is an FDA approved for use to left bundle capturing. With including that, we have CPS located 3D catheter, which comes in 3 sizes, which we will be looking in the next slide. And we have helix locking tool. It is a styled driven lead, so which have a helix. So when we are like extending the helix, when we are advancing the catheter, it might get retracted also. So this helix locking tool will fix at the end of the lead, which will not allow the lead to get retracted or torque torsion to happen while we are advancing into the catheter. So this is the EP setup which we have discussed before. When we are placing the expanded catheter in the expanded area, we could get a small potential, low potential in this. So we can mark the this and we can get the expanded area below this, and we can take our catheter and place in the expanded area, and we can advance our lead and map and we can screw it. So this is the helix deployment. Like when we are advancing the lead into the catheter, the radio of Korea which you see here is the mapping area. So we can take our lead here and we can extend our cathode outside. Then we can map and we can paste the left bundle area to analyze what is the threshold impedance everything. Like in multi-phase lead, we can turn around 8 to 15 turns to get our helix to extend it. And we have this helix locking tool. So this is a conformation area in RIO area. We can get a approximate left bundle area in the normal RV. We can get in the area of 2 to 3 o'clock position in RIO 30. If you want to confirm an LAO, we can confirm the LAO in the degree of 40 to 10 degree in LAO 30. Which if you are not in the correct position, we can counterclockwise or clockwise rotation can be done to achieve the correct area. So if you want to find whether it is in septum, we have an extension flush area where we can flush our dye and we can find out whether it is in septum or it is perforated or. So this is the helix locking tool which I am talking about. So the helix locking tool which we can place in the unipolar and then we can place in the bipolar also. So we can connect our black alligator teeth with the helix locking tool and red to the string. So we can get our unipolar continuous monitoring of the screwing. It will be connected. So when we finish screw, we can rotate the helix locking tool. So we can have a continuous measurements of the impedance. So we can find whether the